First, let's talk about language. PCOS stands for polycystic ovarian syndrome. For most women, we get stuck on that word cyst, and our brains automatically go to things like cystic acne, ruptured cyst, or it conjures up images of Dr. Pimple Popper's YouTube videos. Try to take those images and wipe them away. I'm here to tell you that the word cyst gets thrown around a lot, especially when discussing ovarian cysts, and most of them are normal and expected. The word cyst literally means fluid-filled sac. A typical reproductive aged ovary has a handful of cysts that are present on the surface. These are called follicular cysts and are usually referred to as follicles. These follicles have the potential to grow an egg for the month and be released at ovulation. After ovulation, that follicle gets renamed to a corpus luteum cyst. These normal ovulatory cysts are ever-changing and a dynamic process as we move from week to week in our cycle. Fun fact, follicular cysts can grow up to 2 to 3 centimeters every month during that ovulation period. That's about the size of a small grape or even the diameter of a banana slice. With polycystic ovaries, there's an abundance of follicles present. I wish I could rebrand this and name it multifollicular ovaries as opposed to polycystic. So this particular multifollicular ovary has several sites where an egg could potentially grow and be released for the month. And you might be thinking, this is good, right? The more the merrier? Not necessarily. And that brings us to our main topic. How does PCOS affect fertility? Let's talk about typical ovulation and the different hormones that play a vital role in this choreographed dance between the brain, ovaries, and uterus. Yes, your brain is part of your reproductive system. The first key hormone is follicle-stimulating hormone, and it does just what it sounds like. It stimulates follicular growth on the ovary. Imagine that you have an ovary garden, and each follicle is a potted plant, and each potted plant has a tiny individual seed. Your brain essentially waters your ovaries with FSH until one potted plant decides to be the one who grows for the month. That growing flower pot starts to produce estrogen in the form of estradiol. And it's that budding egg inside that gets bigger and bigger and bigger with each passing day. Estrogen will thicken the uterine lining. It will also help brighten our skin, increase our mood, produces that sticky egg white cervical mucus, and it increases our libido, which is perfect timing because it peaks just before ovulation. That peak in estrogen sends a message to the brain that we need to do something about this growing egg. The brain then sends down a different hormone called luteinizing hormone. This is also known as LH. The LH hormone is what those ovulation predictor kit test strips can pick up. The LH essentially forces the egg out of its blossoming follicle in a process we call ovulation. Try to remember that a positive LH strip test does not mean ovulation is happening that moment. It means that ovulation will likely occur in the next 1 to 2 days following this hormonal surge. After ovulation, the hormone progesterone starts to build and will eventually peak about 1 week after that LH surge. Progesterone is the hormone that's responsible for breast tenderness, fatigue, feeling snacky. Think of progesterone as the progestation hormone because it really is trying to prepare the body for a potential pregnancy. If no pregnancy occurs during this cycle, both progesterone and estrogen levels fall, and that signals the shedding of the uterine lining and an overall hormonal slump, which is why women can feel very irritable, tearful, or more prone to illness, like the common cold in the days leading up to her period and during the menstrual flow. Then the whole cycle repeats itself. Now, there are some key differences in the cycle choreography in women with PCOS. First of all, since there is abundance of follicles present on the ovary, the FSH signal from the brain is not high enough to select a single follicle for the month. There is high LH to FSH ratio, so women will often get false positive OBKs, and sometimes will go weeks without a true surge. If ovulation never occurs, then progesterone will not be present to stabilize the uterine lining. If progesterone never rises, then the body does not get a signal to eventually have a period when the progesterone would typically fall. This can create a lot of frustration when trying to track cycles with the home test strips, timing intercourse around that fertile window that's never letting you know when that's going to happen, or to anticipate when the next period will come. So how can we help reset the cycle choreography? This first line treatment is called ovulation induction. This is where a woman takes a medication, usually letrozole, in the early part of her menstrual cycle. We then want to schedule an ultrasound appointment during the mid-cycle window to assess response to the medication. If there is a growing follicle present, we can usually predict when that follicle will be ready for ovulation. If the follicle isn't releasing on its own, there is another medication called a trigger shot, which takes place at the LH surge. We can then plan for intercourse around this ovulation window or schedule an intrauterine insemination procedure, also known as an IUI. Anytime a woman is taking medication to help stimulate her ovaries, ultrasound is recommended to make sure that 1, there's adequate response to that particular dose, and 2, a safe number of follicles is present to proceed with a potential pregnancy. Producing more than one ovulatory follicle increases the chance of a multiple pregnancy. These risks will be reviewed in detail by your provider before you're prescribed any medication. If ovaries are unresponsive to oral medication, we can give the body synthetic FSH through injections. These medications tend to be more expensive and can increase the risk of having a multiple pregnancy. In other cases, women with PCOS need IVF when other treatment options have been unsuccessful, or if there are other factors present that increase the need for more advanced reproductive techniques. Each treatment option is based on the individual patient's entire clinical picture. Your provider will be able to help determine which is the best course of action for you on your personal fertility journey. I have a lot of women ask me, what can I do to help my PCOS? And the answer is quite a bit. Since PCOS can affect metabolism, mood, sleep quality, self-esteem, there are definitely lifestyle modifications that can be adopted to help with overall body wellness. Try to limit or completely eliminate ultra-processed or sugary foods, and instead try to incorporate more mixed vegetables into your diet. Try to aim for 30 to 60 minutes of daily cardiovascular focused activities. This can be walking, resistance training, swimming, yoga, Pilates, or any other activity that you enjoy. If you find an activity that both you and your partner like, that's even better. Another question I get a lot is what supplements are helpful for PCOS? There's a lot of great literature about myo-inositol and improving ovarian function. There are a lot of brands out there, and we prefer the ones that have the blend of both the myo and D-chiroinositol. Usually these types of supplements can be purchased online or at any health and nutrition store. What about metformin? This used to be the standard first-line treatment that was prescribed whenever a woman presented with irregular cycles and it was suspected that she had PCOS, especially if she happened to be overweight as well. If any of you have taken metformin in the past, it can be a pretty harsh medication on your gut and can cause bloating, gas, nausea, abdominal cramping, and diarrhea. Now we have shifted to prescribing metformin if there is any evidence of being in the pre-diabetic or diabetic range. We have also seen higher efficacy of fertility medications when they are taken concurrently with metformin in women with PCOS who have a BMI of 35 or greater. It should be noted that metformin is not a weight loss medication. Women have reported weight loss after initiating therapy, but this is due to reducing insulin resistance and improving overall metabolism. Also, women tend to avoid foods that trigger those awful GI side effects, like ultra sugary foods, pastries, and other baked goods, so they are naturally eating better in the process. It should not be prescribed to specifically help with weight loss as the primary treatment goal. I know this is a lot of information to digest, no pun intended, but my hope is to address certain myths and misunderstandings that have been associated with PCOS and fertility. For instance, women can absolutely get pregnant with PCOS, and the first step is to understand how your body works and how we can make it work with your particular ovaries. Since PCOS is a spectrum of how it presents in each woman, treatment will also be on a spectrum, and there is not one path that fits all. PCOS affects multiple aspects in the body. Therefore, a multidisciplinary approach that includes improving nutrition, incorporating daily physical activity in conjunction with appropriate medication can increase your chances of achieving a healthy pregnancy. If you already know you have PCOS and are seeking fertility treatment, or if you suspect that you might have PCOS but aren't quite sure, please schedule an initial consult appointment with either myself or one of our other fertility specialists at SRM. Thank you so much for joining us on this informational video today, and we look forward to seeing you as you travel along your fertility journey.